Hi, Stacey.
Hi.
Thanks so much for our very first video interview. And as we at J Hippo are trying to find new ways to talk about the work that's appearing in the journal and to give people a chance to learn a little bit about there's actually real human beings behind the written word. Uh,
Great.
Maybe we could start by you saying a little bit about who you are and what this paper is that we're going to discuss.
Sure, absolutely. So my name is Stacey McMorrow. I'm a health economist and principal research associate at the Urban Institute. This paper is kind of a really high-level overview of some of the successes and some of the potential failures of the ACA that didn't come to pass. We were looking for an angle to kind of talk about the ACA in a big picture way, and the way that we decided to do it, that we being my colleagues Linda Blumberg and John Holohan, we decided to kind of look at a few of the early critiques of the ACA from some of its critics and kind of consider the evidence thus far as to whether or not those criticisms and kind of disastrous scenarios came to pass.
hmm By the way, I should ask, can you say a little bit about what your shop does at the Urban Institute for folks who may not be? I think for people that are really closely involved in the ACA, they pretty much know, but probably some others don't.
Yeah, of course. So we are within the Health Policy Center at the Urban Institute. The Urban Institute has many policy centers, but we all work in the Health Policy Center. We do a range of sort of policy analysis and economic analysis, a lot related to the ACA in the last 10 years. We do both sort of projection simulation type analysis, and Linda and John really lead much of the work on that along with their team. And then I have historically done more of the sort of retrospective analysis, looking back at what happened, particularly at the Medicaid expansion.
hmm There, so there's probably, if you had to identify the very top two or three places in the United States where people have the most institutional and statistical knowledge of ACA, certainly the Urban Institute would be right in that pack.
I think we think so.
And actually, and I would say that other people think so too. There, so maybe we should start with some of the real anxieties that critics had about the ACA, and both reasonable and unreasonable, because some of the
Sure.
things in your paper were things that actually were pretty conceptually reasonable things to worry about,
Yeah,
and some of
absolutely.
them were more speculative. Uh, why did critics fear that the ACA would drive up the deficit and healthcare spending? And to what extent did that actually happen when ACA was passed?
Yeah, it's a good question. So I think there were kind of two main concerns on the spending front. The first was sort of the federal spending side, and that was the concerns about the deficit. So there was a lot of additional federal spending added in the ACA, and there were people who were concerned about that. There was a lot of spending under the Medicaid expansion, as well as the federal subsidies for the marketplace. And so the folks that were raising the sort of red flags about the deficit were really talking about those big federal spending increases, but largely ignoring some of the offsets that were included in the law when they were kind of talking about the likely effects on the deficit. The spending effects were real and did happen, but there were offsets built into the law that led to sort of lesser impacts on the deficit for sure.
How much of that was also kind of luck that healthcare spending was kind of slowing down? So some
Yes.
of the predictions of really increased spending just didn't happen because healthcare spending didn't go up as much as people had feared.
Yeah, and that's really, really important. And so that's something that John Holohan and I have worked on quite a bit, and kind of illustrating just how much the projections of the cost of the law have come down over time since they were first projections were done in 2010 when the law was passed. And since then, we've seen dramatic reductions in sort of the cost of the law over time. And so a large portion of that has been due to the sort of reduced spending growth that was leading into the law, and then that continued well beyond when anyone thought, I think, that it would it would stop. So continued well past the end of the recession and kind of kept going.
Yes, it's interesting that at least in the medium term, healthcare spending growth has really slowed down. I think if you start going on to like 2040, it's
Right.
still pretty scary, but the medium term isn't as bad as people had feared
Yeah.
10, 15 years ago.
Yeah.
Um,
Um,
now,
The other piece on that I think was important was the bigger picture on healthcare spending more broadly and sort of national health expenditures.
Mhm.
And I think there was a real fear there that spending would increase much, much more due to moral hazard. And so people imagined that if many more people got covered, we would see a lot more people getting care and thereby increasing national health expenditures quite a bit more. And again, I think maybe what didn't get kind of considered fully in that instance was that a lot of the people were going to come into the much lower cost plans like Medicaid. And so you are not going to be putting a lot of newly insured people into private health insurance plans, which were growing quite rapidly, but you were putting people into a Medicaid plan, which was actually growing quite slowly. So,
it's interesting that I think when ACA was passed, a lot of people thought, there were the exchanges, which were really the future of American healthcare. Then there was the Medicaid expansion, which a lot of people on the left were sort of ambivalent about.
yep,
Like you're putting people into this lower tier of American medicine. And in some ways, the Medicaid expansion, at least in the states that expanded, has kind of emerged as the jewel of ACA. And,
yes,
and the marketplaces have proved much more problematic. Is
yep.
that a fair statement?
I think so, absolutely. I really think it's been one of the highlights of studying the ACA has been seeing just how far and how broad the reach of the Medicaid expansion has gone, well beyond just insurance coverage and access to care. There have just been a tremendous number of impacts of that expansion that I don't think anyone really fully understood were coming.
Like, well, can you give an example?
Yeah, I mean, I think the fact that the Medicaid expansion has sort of reduced bankruptcies and financial stress, the fact that it's reduced evictions. There have been a number of kind of interesting niche studies kind of looking all across the board at things well beyond healthcare. The eviction study by folks at Columbia is really interesting.
Heidi Allen and her
Yeah. So I think it's been really impressive to see. I mean, I guess it's unfortunate that the Supreme Court made the Medicaid expansion optional, but it has really created an unbelievable amount of research that has used that experiment to really demonstrate the effects of the Medicaid program.
one of the interesting things is the Medicaid expansion has also proved outside of the Deep South to be kind of the future of bipartisan health policy,
Yeah.
and that whereas the marketplaces have not. It's sort of interesting. Colleen Grogan and Christina Andrews and Amanda Abraham, Cliff Versmeer, and I have done some studies on the opioid epidemic, where we
Okay.
talked to a lot of policymakers. And in Ohio, New Hampshire, states that
Yeah.
some of the states that are really being hammered, people would say to us that the opioid epidemic, the combination of the opioid epidemic arriving with the debate over Medicaid expansion, a lot of Republican policymakers said, hey, this is the tool that we
Yep.
have. And we're also kind of accountable for, we own the Medicaid program. And so we
Yep.
either get credit or blame for how it's working. And so it turns out a lot of Republican officials that oppose the ACA actually are really invested in the Medicaid program, John Kasich being the most obvious
Yeah.
example, but many others. Um, Whereas the marketplaces, which are sort of ideologically more moderate,
Yep.
it turns out that nobody owns those except for Barack Obama, and he's not president anymore.
No.
And so I think a lot of Republicans are kind of hoping in a politically calculated way that the exchanges, they're sort of happy that the exchanges have a poor reputation because that's Obamacare.
Yeah.
Uh, but if they're the governor of a state, their Medicaid program, that's a different story. They are
Yep.
responsible for that. And I don't think that we thought about that when ACA was passed and quite that with it, I think we missed some of those dynamics.
Yeah, absolutely. I mean, I think so much of the reasoning for the marketplaces was to appeal to folks on the right who wanted to have a private insurance option. That was one of, that it was built on kind of old policies that were sort of Republican policies. And so it is surprising that really things have everyone has sort of left the marketplaces out there on their own with, the moniker Obamacare is, like you said, the only thing that's left to kind of own them.
Yeah, it's sort of, if we think of, Jay Hippo has a lot of political scientists in the orbit. Yeah. And if you actually think about the incentives that elected officials face, you realize it's not ideological. It's does this program solve some practical problem for me as an elected official? And am I accountable for the performance of this program? And Medicaid for many state elected officials is a problem-solving tool and a source of accountability. That is not the case for the marketplaces. And there is an incentive. There's a political incentive to allow the marketplaces to go into disrepair but I think Democrats would behave the same way if it was the centerpiece of a Republican program.
Right.
If there's no, if George W. Bush had some program that needed some technical fixes, you're a Democrat, you're like, well, this is not.
That's your problem.
Yeah. So anyway, that's an interesting thing. So let's shift a little bit to the impact of the ACA on the labor market.
Sure.
And what was the anxiety around what ACA might do in the labor market, and what do you think has kind of come to pass?
Sure. So this is one of the, I think, much more reasonable critiques of the ACA coming into it. Mm-hmm. So there was a considerable amount of concern that the ACA might suppress labor supply. There were a few different elements that were affected to potentially affect the labor market. Mm-hmm. So the main one being the Medicaid expansion, and the fear there was that people would work less or work not at all in order to qualify for Medicaid, right? Mm-hmm. But there were also concerns about the employer mandate and whether or not that would cause employers to shift their workforce more to part-time to get out of the sort of being in the 50 plus full-time equivalent employee situation. And then just some of the tax increases under the ACA were, there are always fears of tax increases kind of suppressing productivity. But I think the Medicaid expansion is the one that was the most concerning to people and the one that has certainly gotten the most research attention.
And what does the research say?
Largely and very consistently that there's really not much evidence that it has had any impact on labor supply. And it's been a number of different studies by a number of different authors in different places have kind of reached the same conclusion that there really is very little evidence to show that people responded to that incentive by trying to come in under that Medicaid threshold and work less. So.
Why do you think that's a little puzzling?
Yeah.
Why do you think that happened?
It's interesting. So I think there's a few things. I think there's a few things within the law itself that may have had kind of countervailing effects and may have increased people's incentives to work, or at least reduce their incentives to kind of reduce their labor supply. So having the marketplace kind of up against the Medicaid expansion, I think really changed the dynamics that economists are thinking about when they think about that sort of kink in eligibility. So when we're thinking about, if you reach the eligibility threshold and then if you go over it, you get nothing. In the case of the ACA, if you went over it, you didn't get nothing. You got subsidies to buy in the marketplace. And I think that actually kind of changes the dynamic a little bit from maybe what people were expecting. So you don't get nothing when you go above the threshold, you still get something. And so that may have changed things a little bit. There were also incentives in the non-expansion states to increase labor supply to get up to the 100% level and earn a subsidy. So there was some evidence, or there's not evidence of that actually happening, but there's some kind of suggestive implications in that direction. And then just kind of a number of the flexibility options of the marketplace and the dependent coverage expansion really may have allowed people to either work in jobs or keep jobs that they otherwise wouldn't have kept because they had options outside of employer coverage. And so I think there were a few things happening that really beefed up the ability of people to keep working.
One thing that's striking is everybody that I know in academia who's around my age, I'm middle-aged, has a child that was on their health plan,
Right.
till age 26,
Yep.
and that just changes. And clearly, that's bedrock. That's never going to be repealed.
Right.
Uh,
It changes people's options, because you could take a job that was lower paying, you could take a job that you might like, in order to do what you would want to do, if you don't have to worry about getting a job with employer sponsored insurance. But all that said, I think personally, my gut tells me, there's not evidence so much, but that the main reason is because, you can't buy food and you can't pay your rent with Medicaid. And so the incentives to sort of just stop working to get Medicaid coverage suggests to me, that it's just a little dramatic. You still need money. And I think that maybe people sort of in the models estimated the effect of needing income as well.
Maybe someday you'll be able to get food on Medicaid. Jay Geiger, when he went
Yeah,
to the Mississippi Delta in the mid '60s, started writing prescriptions for food.
yeah, and actually housing is coming along too. So
Yeah, so maybe someday we'll all be on Medicaid.
yeah,
Now, by the way, it does seem to me that there's a broader issue that for people that have incomes below like 250% of the poverty line in states that have Medicaid expansion, ACA has been really pretty successful for those people. Uh, they're insulated from a lot of the premium increases. There's a lot of stuff that's happening, but there's clear benefit to a lot of those people. I must say, for people with higher incomes, it's much more problematic. And I think a lot of, it seems to me one of the really disappointing aspects of ACA is for people that have incomes that are above, that are starting to get near the 400% line and above it. And that's what a lot of the public anger is about, where people, and I don't know, what should we do about, if you have a family of four that's earning, like $85,000. So you're not poor, but you're, a middle class person. A lot of folks in the United States, that's not a huge amount of money. Those people often feel like, wow, I'm being offered reasonably crappy insurance on the marketplace. And the subsidy that I'm getting is very, very low. And it seems to me that that's both politically and actually just practically in a human way, that's really disappointing. And I don't know if you have the same reaction.
No, I think that's right. I think the ACA sort of, unfortunately, never promised universal coverage, and it built in a lot of things, kind of to the earlier point, to keep the cost of the law down. And some of those things were phasing out the subsidies and phasing out the cost sharing reductions at these fairly modest levels of income, right? And so it is disappointing that there are still far, far too many people in this country that can't afford coverage and can't afford the care that they need. And so what to do about it is a harder question. It's a question of money, most kind of importantly. I think you could expand subsidies, right? You could bring those subsidies up higher, but you would be spending more money. But I think fundamentally what the problem is that insurance is expensive because healthcare is expensive. And so bringing down the price of healthcare is probably the thing that we need to grapple with if we're really going to solve this problem eventually. And I think some of the conversations around single payer and public options are starting to grapple with that question, because they have to talk about how much are you going to pay providers. And if you're going to make the costs reasonable, it's going to have to be less than private insurance pays them today.
And of course, that is the knife fight. And I was an advocate for ACA, when it was being debated. And I remember, like, I have a relative who's a vice president at a safety net provider in a rural area. And he said, I love universal coverage. I love Medicaid expansion. I love it. Public option, I don't like that part so much. And she said, she basically said, look, if I'm across the table from Medicare for my 58-year-old heart failure patient, the same way I am for my 68-year-old, I'm really worried about whether I can stay open.
Right.
And she was talking to her congressman. She was an important person, in this
Yeah.
community. She's like, I'm one of the good guys. I'm the biggest employer. We're not like an evil insurance company, whatever. We are,
Yeah.
we're a nonprofit hospital that does a lot of good things. And she was clearly using her influence to say, I don't want that price regulation piece of it. I like the
Yep.
universal coverage piece of it because it means I get paid for the
Right.
care that I provide. Things that make me get paid less for the care I provide, I'm a little bit oddly less enthusiastic about. And it does seem to me that is, we got to grapple with that, but boy, that's going to be.
It is going to be, I think it's much harder than people recognize when thinking about, yes, universal coverage is great, but if you are going to continue to pay providers at their current rates, universal coverage is going to be very expensive. And so it's a question, but if you cut them too far, then like you said, people are going to go out of business and there won't be any access to care, so coverage isn't going to buy you very much. So it's going to be an incredibly tricky and I think much longer and drawn out process than anyone is really giving credit to at this point.
Oh yeah, I actually have a solution to that, but I wrote it in the margin of a book, and I put it somewhere in my office. I've forgotten which book I put it in, so it's somewhere.
You have a lot of books back there, so it could take a while.
I do. That's been the problem. Let me just go through some of the other things that you looked at. One is, what has been the impact of the ACA on employer-sponsored coverage? One of the worries was that employers would just bail.
Yeah. I mean, sort of in a word, it's been really modest. It's kind of stayed very, very stable and even ticked up a bit over the time since the ACA was passed and implemented. So the biggest concern was probably that employers were going to drop coverage and send their employees into the marketplace. And that clearly didn't happen. I think the struggles that the marketplace experience have contributed to that. The marketplaces were not the shining star of the ACA. And so I think employers would have been sort of really in a tough spot to say, okay, we're going to send you guys all into this thing that isn't working very well. Good luck.
Yeah.
So I think that was a large part of it. But I also think even if the marketplaces had done reasonably well, I expect that sort of the inertia of kind of large corporations and preferences of employees to keep what they had may have still been pretty strong, even if the marketplaces had been more successful. And also the tax exclusion is still in place for employer-sponsored coverage, and I think that is always going to shore that up as an option. Until that goes away, I think the employer-sponsored market is going to be strong.
Yeah, I calculated the tax subsidy that I get, and it was like $9,000 a year.
Yeah,
That's a lot.
substantial. And I think that it often gets glossed over and people don't. All health economists support repealing it, but the rest of the world is not really on board.
Yeah, it's 350 million to whatever
paltry number of us nerds are out there.
Whatever the annual attendance is at the IHEA conference for health economists, that's the total
exactly.
vote to repeal it.
Somehow we're not winning that battle. I don't know how.
Now, another thing that people worried about was that the ACA, by expanding demand for health care, would kind of disrupt people's ability to get timely care.
Yeah.
And to what extent has that been an issue?
So not very much to the best of our knowledge. I think it's an area that hasn't been explored quite as much maybe as it could have been. Most of the evidence really thus far has been positive, right? And so just general trends are showing access to care improving, coverage improving, doctor visits increasing. All of those things have been sort of on an upward trajectory since the ACA passed. There have been a few studies that have tried to sort of dig down a little bit and understand whether anyone is experiencing some of these capacity constraints or trouble getting care since the ACA. And most of them have found not a lot, but there have been a few little kind of pieces showing some delays and some wait times increasing. So there was a study looking at whether or not the Medicaid expansion affected access to care for Medicare beneficiaries, so for people whose coverage stayed very constant over this time period, there was no evidence there. So there was no evidence suggesting that sort of like an influx of people into the market really crowded out care for Medicare beneficiaries. Then there were a couple of studies on the Medicaid expansion on low-income adults, and those found a little bit of evidence of delays in care due to wait times. And one of those secret shopper studies also found a little bit of increased wait times following the ACA. And so those are out there. The most kind of compelling study on the Medicaid expansion effects showed a pretty decent sized increase in delays in care under the Medicaid expansion in the short term, but that it subsided very quickly. And so that was pretty interesting as well. So it looked like it was really very much a temporary constraint on access that went away over time.
That's basically saying that there's a healthcare marketplace that works like a regular market. In the short term, demand goes up. There's a transient
spike.
There's a bottleneck in supply that eventually works itself out.
Yeah.
I must say, sadly, one of the issues that may also help explain why there's not more delays is that there's differential access. I know that in a lot of the elite academic medical centers, they're just not treating. And some of the, if you have a complicated cancer, it's not completely clear to me that you're getting the. You can go to the marquee academic medical centers and get care from those places.
Yeah.
There's discrimination against Medicaid patients could be part of what's protecting the other patients from delays.
Yeah, that's possibly true too. Although a lot of the evidence that we're looking at that has been looked at is looking at this very low income population and trying to understand whether or not even those kind of the mix of people, which included some people who already had Medicaid and then also the newly eligible, whether sort of on average there was an increase in trouble getting care in that population. And those are the ones that show a short spike and then kind of a subsiding kind of tail there. Yeah.
Question for you. So far in the conversation, there's lots of ways that we've talked about critiques of ACA that turned out to be unfounded.
Yep.
How about the founded critiques? Are there some aspects of ACA that have proved disappointing or that really the critique is accurate, that we need to be thinking about as a society and as a health policy community?
Yeah, so I think the most obvious, I think we already talked about a little bit in terms of the people that there are still so many people who are unable to afford care. I don't think of that as much as an ACA critique because I think the ACA was well aware that it was not going to solve all of the health system's problems. And those of us supporting it knew that it was not going to eliminate sort of all coverage and access problems from the country. But it is, I think, one of the fundamental issues with the ACA. I do think that one thing that I always think of as oversold, and we talked about this a little bit in the paper, is people really, really love to tell the story about how coverage expansions are going to eliminate unnecessary ED use and they're going to increase preventive care and they're going to save money. And I think that most economists are not surprised to learn that that is not true. But it continues to be kind of shared as a reason for passing kind of coverage expansions. And I think that once again, the ACA showed that emergency department use also increases when you make it cheaper. And so
almost like there's a downward sloping demand curve for emergency care.
It's crazy.
I must say, I do see that. I noticed that in the paper, and I do think that was a lapse of integrity by some of the people who support universal coverage and found that it was a politically congenial talking point because there was really never good evidence for that. Now, I think that a more sophisticated argument would be people can use the emergency department better.
Yes.
That if people have options, that And one of the challenges we have, by the way, as a health services research community, I do a lot of research with severely vulnerable populations. People, the way that many of the people that we serve in our interventions, the way they think about the emergency department is not the way that health services researchers wish that they thought about the emergency
Yeah.
department. So, like, there's a lot of people, we did this whole education program at the University of Chicago to educate people that there are FQHCs they could go
Yeah.
to for primary care. And you'd
Yeah.
go to Mrs. Jones, who's 65 years old and lives near the University of Chicago, and say, "Did you know, Mrs. Jones, that there's an FQHC right near your house?" And she says, "I actually do know that because I've walked past it for the past 38 years. And I know 15 people who work there. And because I am not a complete idiot, I actually know very well.
Yes.
I go to the emergency department because I like University of Chicago doctors,
Right.
like everything that they do to try to make it unattractive for me. Also, if I go to my regular doctor, she's going to yell at me because of all the things that my hypertension has spiked because I'm not doing XYZ that she told me to do, and she's going to yell at me. And I actually would rather, I don't want that interaction.
I don't need that.
Yeah, so I like to go to the emergency department. I don't want a relationship with my doctor. What I want is for this problem to be solved, or
Yep.
whatever, or lots of more complex explanations of why people use the ED. And we are very resistant to making the ED match the way that people who use it actually want to use it. We keep wanting to train them to use it the way that we want them to use it.
Right.
And it doesn't work. But I think that's a good one. Is there any other? So you mentioned the failure of sort of universal coverage and sort of the limited ambition of ACA for the whole society, and the ED issue. Any other big disappointments in ACA?
Yeah, I guess I don't know if I would call it a disappointment, but it was a surprise to me, at least. Is I think I've been surprised at how unimportant it turns out the individual mandate has been. And so that was, there was so much energy spent on defending it to the Supreme Court and fighting to keep it. And just so much that it was this third pillar of the law. And again, this was, universally shared by all the economists, the adverse selection death spiral, it's going to happen if we repeal the mandate. And the marketplaces, while they're still kind of struggling along at less than maybe we had anticipated, they have not at all fallen apart with the repeal of the individual mandate. And I've been surprised by that. And maybe it's because it was never strong enough, but it was definitely, I was right there with everyone else saying, like, we absolutely have to have this thing. And it turns out maybe we don't actually have to have that thing.
Well, partly you have a group of people for whom there's such heavy subsidies for their health insurance coverage that that you've got that, and you've also got the Medicaid takes some of the people out of the pool who would be the toughest. I must say, this issue, I'm older than you, so I actually remember when the individual mandate divided progressives because Obama was against it and Hillary Clinton was for it, and then as soon as Obama came in,
I'm not that young.
Well, I'm just older. So it was striking how many of us flipped around our view of that, which is probably a chastening example of how we, at any given moment, we always regard our own current position as bedrock, and that bedrock has a way of moving,
of shifting.
Yes, there. So the individual mandate, that's an interesting one.
Yeah.
And do you think that the ACA, now there was also the hope that the ACA was going to create some system improvements, in addition to whatever it did to healthcare costs and coverage and access, that it would help us create a more evidence-based, higher quality healthcare system. Has that happened to any extent in a way that we can say the ACA was helpful?
I think there's been a fair number of sort of experiments under the ACA, and some things that have been attempted under the ACA, and bundling payments and sort of readmission penalties and things like that have tried to go down that road and to greater or lesser successes. It's not really my area of expertise in terms of all of the different kind of programs that were put in place to test various kind of quality improvement initiatives. but I do think that they have been implemented and they have been tested, and some have been found more successful and others less. But I don't know that it has taken us to a more evidence-based system at this point in time. I don't think I can see the evidence of that.
And that seems like a fair point. So
Yeah.
just as we think about reaching the end of our conversation, two questions.
Yeah.
One is there, what's the question that I should have asked you that I didn't ask you?
Ooh. That's interesting. I hadn't thought about that. I guess, I mean, I think we touched on this earlier because this is something that I think about a lot, is I've just been tremendously excited and impressed by the evidence on the Medicaid expansion and the Medicaid program.
Mhm.
And so that is the thing that has really like risen to the top for me in the past sort of 10 years plus. It's amazing to me that a program that was always associated with such stigma, and that no one would possibly want to enroll in Medicaid, and what would we ever, why would we ever put anyone in this program, has just been so successful beyond, I think, anyone's wildest expectations.
Mhm.
And so that to me has been really heartening for someone who has worked on Medicaid for a long time and really believes in the program and always has. It's been great to see other people get on board and really understand how important this program is to so many people, and probably so many more people that you know than you realize. And so I think that's really been pretty tremendous for me.
And it turns out that it's important to so many stakeholders
Yep.
that it,
Yeah.
that it is, rural hospitals, state governments, as a source of employment. It is really, it's just really important to a lot of people. There is, by the way, one weird backlash to the Medicaid expansion that I'm thinking when Sarah Cliff, when she was at Bach, she's now at the New York Times, she went to sort of parts of West Virginia, Kentucky, I believe it was Kentucky actually, and talked to people, and basically said, like, why is everybody voting for President Trump in this county where
Yeah.
where so many people have benefited from the Medicaid expansion? And there's actually a complicated story behind that, because there's a lot of people who benefited from the Medicaid expansion just don't vote, and it's their neighbors who do vote. And it turns out a lot of people, including people who are like involved in helping people enroll in ACA, would say things like, I'm on this crappy insurance. Maybe it's a marketplace, maybe it's my employer, and my cousin, who's a total screw up, like, he's on Medicaid. He can go to the emergency department for free, and like, that's not right. I don't feel good about the fact that this unworthy poor person actually has
Yeah.
better health insurance than I do. And it is sort of a weird, in the long run, by the way, I think that becomes an argument for expanded public insurance. But you can imagine, in the short run, it has had some
Yeah.
unexpected political bank shot effects, because there is a certain resentment towards towards the high actuarial value of
Yeah.
what's available in Medicaid.
That's a really good point. And I actually thought you were maybe going somewhere else with that, where I think there was also issues in Kentucky where the Medicaid expansion was vastly, the marketplaces were vastly more popular because they were called Connect and not called Obamacare. And so the names can also be tricky, I think, if you don't call it Medicaid. And I think many states have gotten away from calling things just plain Medicaid. They call them by some state-based name, and those also seem to be a little more popular. So there is still a little bit of stigma there in the works, but I think it really has been just such a tremendous success that it's been great to watch.
Yes, I'm on Badger Care. I'm not in Medicaid.
Right.
So you did this JHIPPO piece,
Yeah.
and what are you working on these days?
I've actually been doing a bunch of work related to women's health and reproductive health. So we have a piece that is hopefully coming out soon, looking at the effects of the Medicaid expansion on insurance coverage for new moms.
Mhm.
So kind of feeding into a lot of the debate on maternal mortality and postpartum Medicaid coverage. And so we showed that there's a lot going on there. I can't talk too much about it until it comes out, but it should be out in pediatrics shortly. So we are excited for that. And then have some other work going on related to that, looking at postpartum Medicaid expansions, and trying to focus on the impacts of the ACA on contraception use and unplanned pregnancy as well.
You stay away from the controversial stuff, I see.
Yes, of course.
Well, it's been a blessing to talk to you and to learn about your work. And thank you so much for setting aside some time. I'm going to